Few industries in the world demand as much scrutiny and regulation as pharmaceuticals. In medicine, quality is non-negotiable.
The World Health Organization.
Since 1948, the United Nations body, the World Health Organization, has been the foremost authority on pharmaceutical standards around the globe. Only companies who successfully pass their rigorous inspection process are awarded the World Health Organization pre-qualification standard. This seal of approval ensures customers that a brand of medicine meets the strictest safety and quality control standards in the world. Of 900 pharmaceutical companies, Getz Pharma is the only organization to have received this certification. Our facilities are equipped with state-of-the-art machinery explicitly designed to prevent cross-contamination by using continuous environmental monitoring. All our raw materials are procured solely from WHO or US FDA-validated suppliers and are carefully audited before they are declared compliant. Our quality control laboratories and product testing departments remain at the forefront of our manufacturing process. A series of stability testing procedures allow us to guarantee that our medicines maintain their quality long after they've been delivered to pharmacy shelves. We have taken great care to simulate environmental conditions to ensure that medicines retain their efficacy and longevity in our particular climate. In accordance with WHO guidelines, our employees are highly qualified and regularly receive training in Europe and Japan, keeping us at the cutting edge of rapid advances in pharmaceutical research. Our quality guarantee makes us the only pharmaceutical company which can sell medicine to global bodies such as UNICEF and that are approved for sale by international markets. Today, Getz Pharma is the single largest exporter of pharmaceutical products. But more importantly, our WHO certification means that doctors and patients have access to the best quality medicines in the world at affordable prices. At Getz Pharma, we are proud of this achievement. We believe that our people deserve the same access to quality medicines and medical care the world over. Because where you live should not decide if you live.
Good afternoon to you all. On behalf of Getz Pharma, I would like to warmly welcome all of you for today's webinar. Our speaker for today's webinar is Dr. Channa de Silva, Consultant Pediatric Pulmonology at Lady Ridgeway Hospital, Colombo. Dr. Channa de Silva has board certified as a specialist pediatric pulmonology with effect from 2016. Dr. Channa de Silva has MD Pediatric, Postgraduate Institute of Medicine, University of Colombo, MBBS, Faculty of Medicine, University of Colombo, and Gold Medal in Pediatrics. Dr. Channa de Silva has obtained specialized training, first MD trainee in Pediatric Pulmonology, Pediatric Respiratory Medicine in Sri Lanka, Senior Registrar in Pediatric Pulmonologist at Lady Ridgeway Hospital, Chest Clinic Colombo, and Chest Hospital Valisara. Specialist Registrar in Pediatric Pulmonology, All India Institute of Medical Science, New Delhi, India. Senior Clinical Fellow in Pediatric Respiratory Medicine, Royal Manchester Children's Hospital, Manchester, UK. Sir, it's a great honor for us to have you as the today's speaker for this webinar. Dear participants, if you have any questions, you can post it on chat or Q&A section. Sir, over to you to conduct the today's webinar.
So thank you very much for providing this opportunity for me. And today, over the next 30 to 40 minutes, I'm going to discuss about this MART. It's a relatively new term, but not a brand new term for the world. There are a lot of studies going on these things, but it's still new for pediatric practice. And there are some controversies still going on, and still no one knows exact beneficial effects of this thing. I'm going to discuss a little bit about the available evidence and current recommendations and possible use of this approach in the management of asthma in children. Before going into the specific things, so these are the things I'm going to discuss about. This is first thing about the definition of asthma, and then there's some description about the MART therapy and the Formoterol. So this is one of the key component is MART therapy because of some sort of properties of Formoterol that make this MART is possible. So we discuss a bit about that. And other thing is the long-term use of SABA-only treatment. There are some dangers about this, and that is one thing which lead to people thought about using this MART therapy. And then the evidence of MART. There are a lot of papers, but I just selected a few. And the recommendations. So we mainly follow the GINA recommendations at the moment in Sri Lanka and most of the other countries in the world. So the final recommendations on GINA, and finally, what is the place of MART in children. So before going to discuss specific things about MART and the evidence and the rest of the things, I thought we would discuss about the definition of asthma. So this, I am sure that you have already know about this thing. Just to refresh, and I have also discussed several cases about these things. But I just want to stress is this GINA definition. This is very important, and so it is very informative definition. So this definition describes various things. These are the things which make the basis of the whole of the management. So the different approaches, different age groups, different categories, like MART also is a little different approach. So all these things because of this the features of asthma. So that feature. So this the unique nature of asthma is defined with these definitions. But the problem is still no one knows how to exactly define asthma. So that's why the GINA also use various sentences. It's mainly some sort of description of the exact characteristic of asthma. Still no one was able to find some sort of simple single sentence definition for asthma. So GINA explained that asthma is a heterogeneous disease. It is one of the most important statements. I'll come to that in minutes time. And its other thing is it's characterized by chronic airway inflammation. This is we know. So asthma is basically a inflammatory conditions. In fact, that is the commonest chronic inflammatory condition in children as well as adults. So, and it is so that it described, further defined by its respiratory symptoms. We know that it's mainly asthma is associated with four clinical symptoms. That is wheezing, shortness of breath, chest tightness, and cough. But the thing is, none of these symptoms are specific to asthma. So any respiratory conditions, any respiratory illnesses can give rise to these symptoms. But the collection of these symptoms, the pattern of these symptoms is pointing towards possibility of asthma. Another classic feature is they are vary over time as well as intensity. So that is the nature of asthma and associated with variable expiratory airflow limitations. So this variability is one of the classic features of asthma, which differentiate it from other forms of respiratory diseases, sometimes presenting as almost similar as asthma episode. So it's a heterogeneous disease. So what is the meaning of this? I'm sure that you know about this thing, but just to recap that, asthma is not a single disease, so single description of a single disease. It's a umbrella term. It's an umbrella term. So if I take some other two examples, it's same as arthritis or anemia. We know anemia is not a single disease. We don't treat anemia. If we identify a child is having anemia, we do a lot of investigations to identify what is the type of anemia. So type means that is a pathophysiological process which finally leading to anemia. So asthma is also same. There are a lot of pathological processes behind that going on to giving rise to various symptoms of what we finally termed as asthma. The thing is, we know the types of anemia, we know the type of arthritis, but still we don't know what are the exact type of asthma. That is because it's a significantly complicated thing. So if we consider anemia, if I represent this anemia, different type of anemia in as one colored square, so iron deficiency anemia represented by this green square, vitamin B12 deficiency represented by blue square, like that, the sickle cell anemia. So there are several kinds of anemia. If we represent these types of anemia with a different color, usually there is no overlap between these colors. That means these colors are very clear. That means these pathological pathways of different types of anemia are very clear. Usually there's no overlap between iron deficiency anemia and G6PD deficiency. So they are distinct clinical entities, even though the final expression is anemia. So when we discuss about these phenotypes, which is very important, the problem in asthma is it is not that as simple as like describing anemia or identify the different phenotypes or endotypes of anemia. So the asthma is these phenotypes are completely mixed. So we cannot clearly make a square of, say, example, a blue color square, which represents the neutrophilic asthma or the atopic asthma. So the thing is, the final, the clinical presentations of individual children depend on the collection of these different pathways. So the child sometimes say, example, this area. So this the child with this type of asthma might have some sort of atopic sensitization, and there might be associated metabolic syndrome, for example, this child, and this child might have neutrophilic involvement as well. So the combination defines the final comment or the final outcome of this. So with this, there are a lot of phenotypes and endotypes. So this approach is important. Identify the exact endotypes and phenotypes with asthma, because finally the MART treatment and all these things, the effectiveness of all these things depend on this. So there are a lot of phenotypes. I'll just come to that in a minute time. Endotypes. Endotypes seems to be the most important, but still we don't know much about these endotypes. That is, endotypes are the pathophysiological mechanisms which lead into these clinical symptoms. So at the moment in asthma, they have identified two the major endotypes, that Th1 mediated or Th1 predominant asthma and Th2 predominant. Th2 predominant asthma is the classical allergic asthma, but still the Th1 predominant neutrophilic involvement in the asthma also is possible. And there are a lot of genetics as well as epigenetics. So epigenetics, how this genetic background is shaped by the environment. So that is also important because all children with genetic background they don't develop asthma. So the epigenetics, that environmental interactions also important. So it's a balance between the genetic as well as the environment. So sometimes these epigenetic descriptions or the changes in the non-coding areas of the genetic, the genes, epigenetics would be the link between the genetic and the environmental influences on final shape-up of asthma. So, and the phenotypes. So different individuals have different phenotypes. So they are the children with this, or children and people with asthma. So different phenotypes, their genetic background, the age at onset, the clinical presentations, the combination of symptoms, severity of these symptoms, and the response to treatment, the frequency or the recurrence of these attacks, and the final natural history when this asthma gets completely settled. All these things are unique to individual patients. So in these backgrounds, even the MART therapy, whatever the treatment, so according to this final the response and all these things depend on these phenotypes, endotypes, and the various underlying mechanisms. Sometimes, or not sometimes, most of the time, they are still need to be yet to be defined. Still, we don't know. So depend on that. Like, so we finally describe the which step this child is belongs, whether it's a step 1 or 2 disease, step 3 disease, controlled disease, uncontrolled disease, whether the MART treatment is work in this child, whether there's some other treatment. So all these depends on these things. So I'm going to discuss this MART from this background because it's very important. Individual child is unique. Their genetic environment and all the factors, exposures, triggering factors are unique to each children. But fortunately, most of these response to our treatment, when we categorize them as step 4, according to the control or whatever the available categorization, but still we have to keep in mind anytime these children might not respond to our routine management because the management options for one child might not be suitable for another child because it might be 2 different diseases, even it's diagnosed as asthma. So the final, whatever this background things, the final, our goals are, there are certain things we have to improve the control and we have to reduce the risk. That is the 2 major most important goals. So while improving the controls, we have to achieve or symptom control as much as possible. We have to try to normalize the lung functions, and especially when we are dealing with children, so the functional status and the quality of life is important. We know that children are suffering from asthma and parents, they might unduly restrict activities. So the final goal of this asthma management should be to allow these children to live as normal as life as possible as the other children. So they should be able to play, do physical activities, wash, swim, would be able to take the meals, cool foods, ice creams, all these things. So finally, the goal should be this. Other thing is reduction of this risk factor. The primary thing is prevention of death. Any child should not die with asthma, and reduce acute attack and reduce unscheduled emergency care. So especially this type of things improve or increase the risk of possible adverse outcomes, even death. And other thing is, while achieving all these things with drugs, we should minimize the side effects of drugs as well. So the MART, the approach, the one reason for this, people thought initially thought about the possibility of use the same inhaler, single inhaler for both relief and maintenance therapy. One is to minimize the treatment side effects. So those things are important when we discussing specific kind of management option. So what is MART? So it's a maintenance and reliever therapy. So initially, the studies were going on these aspects, mainly industrial sponsored. So it's through one company, and their product was Symbicort. So because of that, initially it was introduced as SMART, S-M-A-R-T, that is Symbicort maintenance and reliever therapy. But now, as it's become a generic term, the SMART is now single maintenance and reliever therapy. So here there are 2 components, as you all know. So maintenance therapy and reliever therapy. Why there is a need for maintenance therapy? Because as we mentioned, as we discussed already, asthma is an inflammatory condition. So definitely in long-term treatment of asthma, to achieve the symptom control, to achieve prevent the exacerbations, we have to control this inflammation. So anti-inflammatory medications, there are a lot of wide range of anti-inflammatory medications available. So one thing is we have to use regular maintenance anti-inflammatory medications. Out of these various anti-inflammatory medications, inhaler corticosteroids are the cornerstone of management of asthma. In 1992, this is the first time this international consensus report on diagnosis of treatment of asthma, first time they announced that chronic asthma should always be treated with ICU. So that statement is very important. So chronic asthma should always be treated with ICU. So that means there should be some maintenance treatment to tackle this inflammation. And the rest of the thing is reliever treatment. So with background of these inflammations, the other important thing in final exacerbations or the symptomatic, the cause for symptoms is bronchoconstriction. So that is associated with this variable expiratory airflow limitation. So because of that, there's a place for reliever to give rise to some sort of temporal improvement, temporary bronchodilation. So there are two agents available. So short-acting bronchodilator agents, the SABA, and the long-acting bronchodilator agents, LABA. So what is the most suitable in the long-term management in the achieving asthma control as well as prevent the risk of future exacerbations by preventing the risk of significant morbidity and even mortality. So in MART therapy, and this when we consider this reliever therapy, one of the cornerstones, the most important the drug is the formoterol, because the properties of formoterol make this possible. Because formoterol, it's a long-acting bronchodilator agent, obviously. However, it has some properties of salbutamol or short-acting bronchodilator agent. There are a lot of studies, some studies going on to assess the properties, pharmacokinetics and dynamic properties of formoterol. And this study was published in 1998. It is one of the sorry, very good study. It compare. It is in this study they have induced bronchospasms by giving methacholine, and then they use salbutamol and formoterol to relieve this methacholine-induced bronchoconstrictions, and they assess the airway resistance and the airway dynamics to assess the bronchodilation, the efficacy of effect of bronchodilation assess. And this study they have found the onset of action of salbutamol, it's around 3 minutes. Within 3 minutes, salbutamol gives clinically significant bronchodilator effect, but same as formoterol, even it's a long-acting bronchodilator agent, its onset of action is almost same, and within 5 minutes, it gave a clinically significant bronchodilator effect. So this property is very important. Although it's a long-acting bronchodilator agent, its action is persisting at least 6 to 12 hours. Its onset of action is also within 2 minutes. So because of that, it can be used as a reliever as well to give rise to instant results of bronchodilation. But this property is only confined to formoterol at the moment. That's because salmeterol doesn't have this property. Salmeterol onset of action is delayed. So other thing is we cannot use salmeterol few doses per day. But formoterol, if we can go up to 72 micrograms per day. Usual our inhalers contain 6 micrograms of formoterol. That means if it is really required, we can go up to 12 puffs per day. So then the combinations, usually most of the available studies done with the combination of formoterol and budesonide, but now some studies available with the formoterol and beclomethasone as well. Other thing was the asthma management. So one of the important thing in this use of this maintenance and reliever therapy is patients with infrequent asthma. So infrequent asthma is the mild forms of asthma patients, especially these studies, most of these evidence studies done in adult patients, and if it is done in children, it's all these almost are were done children over 12 years of age. So there are no published valid studies, so significantly valid studies done in children less than 12 years of age. So especially adult patients, the practice of using short-acting bronchodilator agent, salbutamol, albuterol, terbutaline inhalers when they are having symptoms. So inhaled this short-acting bronchodilator agent. That was the first-line treatment of asthma for 50 years. Still, our guidelines says salbutamol is the first-line treatment of asthma. So because the general perceptions, even with doctors, general perception was asthma is a condition of bronchoconstriction. So because of that, asthma attacks could be relieved with bronchodilation. So prevention of bronchoconstriction is the answer to the acute attacks or management of asthma. And patients feel that once they just take a salbutamol inhaler or short-acting bronchodilator agent, they feel better or improvement if the instant improvement of their symptoms. So that's it. So their belief was my reliever gives me the control over asthma. So then especially patients with mild asthma, this was the issue. But many studies showed, so this study is especially quoted in GINA guidelines. So patients who had apparently mild attack or mild asthma also have possibility of development of severe episodes. So in this study done in 2007, published in 2007, so infrequent symptoms, the patients last 3 months, patients who had less than weekly symptoms, but 30 to 37% of these people had acute asthma, adult patients. 16% had near fatal asthma, and 15 to 20% died of asthma because the background asthma was mild intermittent asthma, but they also have a possibility of developing into severe asthma if they only use salbutamol. That means if they only use the broncho dilator effect, but without addressing the underlying or background inflammation. So this was further, with further evidence suggests if this is again in adult patients, if they use more than 3 or more canisters per year, that means about 1.7 puff a day without using a proper control agent, without using a proper inhaled steroids, so only using salbutamol or short-acting bronchodilator, this is associated with higher risk of emergency department presentations. And if they are using or more dependent on short-acting bronchodilator agent, use 12 or more canisters per year, this is associated with higher risk of death. So with background of these things in world, the people, the researchers, investigators in world thought the risk of this salbutamol only treatment or risk of this reliever treatment without use of proper control medications should be stopped. And this was published in 2019 in the European Respiratory Journal. This editorial, these editors suggest that is it time to move away from short-acting beta agonists in asthma management because of this risk. And this background, the value of MART using the inhalers contain both reliever and controller medications. The value of this treatment again came into the higher position. So other thing is, so people use short-acting bronchodilator agents when they are having some sort of acute asthma symptoms, so acute cough, or when they are having symptomatic, especially in patients with infrequent symptom, is they are not like to, or they are unwilling to continue regular inhale corticosteroids or regular maintenance dose. So this is the one of the major issues, the adherence to treatment, especially inhaler corticosteroids, especially if they are having infrequent symptoms, infrequent mild symptoms, especially GINA step 1 and 2. So they have noticed that when they are using only this intermittent steroids and intermittent short-acting bronchodilator agents, they have noticed that the use of the steroids, so some sort of control medication just before exacerbation is significantly less, and after they develop this exacerbation, after that, then the adherence is increased. Again, when the little time, few months is going on, again they stop this treatment, and again if they develop some sort of acute wheezing episode, they'll start to trek. So this cycle is going on. Oh, that is another thing. It thought about using the same inhaler to give controller medications in addition to the bronchodilator agent. So that is one of the important things just they consider using this MART therapy, or the basis of MART therapy. So what are the evidence? So with this background, many researchers thought about this in mild asthma, GINA step 1 and 2, the use of MART. the use of same inhaler, combined inhaler with long-acting bronchodilator agent as well as control medications or the inhaled corticosteroids. One of the important study, actually this is also funded by industry, but this is the major study that quoted in GINA guidelines. So GINA used this evidence for their recommendations, and you can see it in the GINA guidelines. So this one of these main study was Sigma study published last year. The Sigma, the means is Symbicort given as needed in mild asthma. This was double-blind randomized control trial done in multiple centers with 8,000 participants over 52 weeks. It was going on 2 phases, 252 weeks. That means 2 years, 1 year, 1 year. And this was done in patients over 12 years, adults and adults. In this study, they used 3 arms in the initial study. One, they used regular placebo, daily twice a day placebo plus terbutaline. Terbutaline used as a short-acting bronchodilator. Some other countries they use terbutaline, although we use salbutamol. So they use regular placebo with as needed short-acting bronchodilator agent, and they use another arm regular budesonide formoterol with the regular placebo and regular actual the controller steroid plus terbutaline as needed. So basically, so they use these 2 placebo just to mask, to blind this thing, but basically they use budesonide terbutaline, giving budesonide daily and giving terbutaline or short-acting beta agents intermittently. That's what is using the current practice. And in this arm, they use, instead of giving only short-acting bronchodilator agent, they gave it as needed. Both inhalers contain both bronchodilator agent as well as the corticosteroid. And other arm, it's only the short-acting bronchodilator agent intermittently. So these patients were grouped into 3 arms. So one arm received daily baseline steroids plus intermittent short-acting bronchodilator agent. One group intermittent combined inhaler, the MART treatment, and other group intermittent short-acting bronchodilator agent. So the interpretation of this study, they have identified that. So as needed, budesonide formoterol or it provides superior asthma control in comparison to the as needed SABA. So when they consider the symptom control, just giving intermittent short-acting bronchodilator agent is inferior in comparison to intermittent both formoterol and budesonide formulas. That means short-acting bronchodilator agent only treatment, its efficacy to control symptoms was inferior. That means the inhaled steroid plus long-acting bronchodilator agent arm was superior to controlling asthma symptoms. But if we consider to other arm, it was inferior to the regular. So that means to intermittent symptoms also, to control intermittent symptoms, regular steroid is still the most important management option. But there's a definite place for intermittent combined inhaler than intermittent only short-acting bronchodilator agent only treatment. And other thing is, if when they assess the risk of exacerbations, that is one of the important findings. Both intermittent the steroid containing and the regular steroid, both were similar in reducing the exacerbation rate. That means, so the practice was usually symptom-driven approach. Symptom-driven approach means, so intermittent this treatment with the combined inhaler contain formoterol and steroids, usually budesonide. When they feel, when they are having symptoms or starting cough, they used to take this combined inhaler. Or another arm, they continue with the daily steroid inhaler. So the ability to prevent further exacerbation was similar in both groups. So that is one of the plus points in this use of this single inhaler. Other thing is, another plus point for the single inhaler is when they assess the final steroid dose, so this study was going on for 1 year duration, the significantly lower dose of steroid dose used in intermittent dosing of budesonide formoterol arm than regular budesonide arm. That is obvious. No? So rather than continuing baseline maintenance therapy, the dose is significantly less if they use intermittent dosing regime. However, there are some issues. And there are another recently published 2 studies. One is called this novel stats, another is a practical study, almost similar designs, almost similar investigations was done with some sort of different drug combination. So they also found that budesonide formoterol used as needed was superior to short-acting bronchodilator agent only treatment. They have used albuterol at that time. But the thing is, these studies, all these studies, and some of these, most studies are funded by some pharmaceutical companies, the results were statistically significant. The p-value was less than 5%. But one study, the p-value was 4.6%, still less than 5%. But when they assess the value, the reduction, one study, the reduction was one arm is 30%, and other arms 34%. So the problem was this the difference, small difference in numbers, whether these are clinically significant or not. And there's another study published last year, this SENA study. They used assess the patients with mild persistent asthma. 3 arms were, one arm they used mometasone as the steroid, another arm they used tiotropium, that is long-acting acetylcholine antagonist, and another arm placebo. So the interesting finding this study was, so they also used the group was mild asthma patients. They had intermittent symptoms. They assessed the sputum eosinophils level of these patients. So sputum eosinophils levels were low in 73% of patients. So the important message here is some patients with intermittent symptoms, according to studies, most patients, almost 3/4 of patients didn't have eosinophilic mediated type 1 classic asthma pathophysiological process. So because of that, they have identified that there was no significant difference in their response, either mometasone or tiotropium. So even they use steroids, there was no response in comparison to because the effect in both mometasone and tiotropium arm was almost similar. So that's why I just started with this discussion. So all these the response to the treatment depend on the phenotypic and endotypic type of this patient. So if it is not a classic eosinophilic pathway, sometimes steroids might not work. So when we considering patients to start this, we have to consider all these things. But the thing is, we cannot identify or externally, we cannot identify if they are endotype or phenotype. But the thing is, if they are not responding to our treatment, then we have to consider some possible alternative methods. So most of these studies done in adult patients, and this study published in 2018, they have assessed the budesonide formoterol maintenance and reliever therapy in adolescents with asthma. So it's adolescents they use. So this is done in step 3 treatment. So we know the step 3 already. Step 3, we add long-acting bronchodilator agent to inhale corticosteroid. So one of the main important utility of this MART therapy is use the same inhaler, the single inhaler, as both reliever as well as the maintenance, the method of inhaler. So this is called this single inhaler therapy. It's a concept of single inhaler therapy using the same inhaler as the reliever as well as the maintenance therapy. Our usual current practice is to continue a combined inhaler or steroid containing inhaler as a daily dose to achieve the symptom control or to control the underlying inflammatory process, and use short-acting bronchodilator agent when patient is having symptoms. That is to achieve temporary bronchoconstriction. That is, so 2 different relievers and 2 controllers. But this therapy using the same inhaler, again same, it's contained the formoterol. So it's only with formoterol we can use this, or we can achieve this objective. So budesonide. it is not essential, but most of the UK, it's only that they approved budesonide contained combined inhalers with formoterol, but even beclomethasone, formoterol combinations also available. So these studies, and there are some other studies also, one of the main thing is this is important to overcome the poor adherence. So no need to use two inhalers, especially adolescents. They can use this as the same inhaler. They can keep it with them while they are attending schools, other educational things, playing, sports activities, anything. So they can keep the same single inhaler and use same thing daily as twice a day dose or whatever according to their the level of asthma degree of severity, and same as using the same inhaler when they feel they are getting some sort of uncontrolled symptoms of cough or shortness of breath or wheezing, anything. And so the advantage of this approach is when they use the same inhaler, the purpose of achieving bronchoconstrictions or bronchodilatations, the purpose of ameliorating bronchoconstriction, automatically they get some additional steroid dose as well. So obviously these symptoms appear because of this uncontrolled inflammation. So say example, if they feel some dizziness or wheezy or cough after doing some school playing activity, so they can use the same inhaler. So this will give bronchodilator agent. So when they are using this formoterol, it give the results almost similar as salbutamol. And meanwhile, if they use this additional doses during this type of situations, they automatically receive additional steroid dose as well. So this is important. So this concept, so anti-inflammatory reliever. So the relieving effect with the formoterol rapid onset of actions as a reliever to induce bronchodilatations. The same time they receive additional doses of steroids, so anti-inflammatory effect as well. So the single inhaler therapy containing budesonide and formoterol contain formoterol with some sort of steroids act as an anti-inflammatory reliever medication. So this is important, especially adolescents, to improve their compliance. So this age, the compliance, adherence to treatment is one of the major concerns, especially that is one of the major reasons to develop the acute exacerbations or to develop uncontrolled asthma. So in that sense, there is a definite place in children, especially older children less than 12 years of age. But what is the place of MART in small children less than 12 years? Still, we don't know, because there are no studies or convincing evidence regarding the safety of this approach. If we consider or if we extrapolate the evidence in adults and older children, we might think that there may be beneficial effect. But the problem is all these depend on type of inflammation. As I mentioned in one of the previous study, that study, the eosinophil count in the sputum was significantly less in a majority of patients, and they didn't respond significantly, or they didn't show any added important advantage. So the same thing, still, say example, preschoolers, the wheezing symptoms is mainly due to viral infections, and most of the time this inflammation associated with viral infection is neutrophilic mediated. So the place of steroid would be controversial. So in that type of situation, use of the traditional ordinary short-acting bronchodilator agent would be enough, because steroid might not give significant beneficial effect on neutrophilic inflammation. There might be beneficial effect, but then when we consider in the side effects, the benefits would not be that much great. So all these things we have to consider in considering children. So because of that, still we don't, the studies are not going on in this age. Other thing is the safety. Still we don't know the safety of this using this long-acting formoterol in long term, because obviously, as we know, if we give a long-acting bronchodilator agent in a prolonged period, it obviously associated with downregulation of these beta-agonist receptors, and if the child develop acute attack, so then the action of short-acting bronchodilator agent also be hampered. So that is one of the other significant concern. So because of that, even GINA guideline, any guideline, there's no recommendation to use this MART approach or single inhaler therapy approach in children less than 12 years. So we don't know in future what would be the results. The positive thing considering this MART therapy is the single inhaler that is important to improve compliance and is a little handy rather than using two inhalers. And the same time, if they get some additional steroid dose as well, because with the current approach, when they having some sort of symptoms, we give only additional salbutamol, only reliever therapy only. But with this approach, they get additional steroid dose as well. That might be important to prevent exacerbations, especially the exacerbations. The definition of exacerbations is taken in most of the studies as increasing asthma symptoms which require systemic steroids. So one of the major target or goal of this management is to prevent the requirement of systemic steroids. But unfortunately, our setup, we are also using this some sort of MART therapy, but thing is we use oral steroids, oral prednisolone most of the time, even with a very mild attack. So that is not suitable, because obviously you know about the side effects and the issues with the recurrent use of these steroids. So that's why inhaled steroid came into this picture and possibly showing some possible beneficial effects, but still it is not evident in small children. So because of this, with this background, so GINA has changed their management approach, and 2019 they did some sort of fundamental change in asthma management, but that is still only with older children less than 12 years of age. So they have changed the preferred control option in step 1. So step 1, initially, we use short-acting bronchodilator agent alone treatment when a patient has some sort of wheezing episodes or cough or evidence of increasing or exacerbating their asthma symptoms, infrequent mild symptoms. We asked to use as needed short-acting bronchodilator agent, but considering the background of inflammation, need of control of this inflammation, because asthma is an inflammatory disease, although there are some evidence mild asthma might not have the classical the eosinophilic inflammatory response. So GINA recommend, based on current best evidence, so they no longer recommend use of salbutamol only treatment or short-acting bronchodilator agent only treatment as a preferred control method in step 1. And the step 2 and step 3, instead of using short-acting bronchodilator agent as a reliever, they advise, if they are already using the Formoterol containing inhaler, use that as a reliever therapy as well. So the preferred reliever as needed low dose ICS Formoterol. So that is the preferred one. But initially, all steps had this short-acting beta-2 agonist, SABA, that is gone into the bottom. So now it is the other option. It's not the preferred option. So this is the major change according to this current available evidence GINA has made last time, but still they use the same old recommendation for children less 6 to 11 years as well as preschoolers, because still we don't know, as I mentioned earlier, the safety of this approach and the appropriateness of this approach, as well as the effectiveness of this approach. So still we need a lot of data, a lot of evidence to support this approach to use in children less than 12 years as well. So at the moment, there is no significant place of MART in small children. So in summary, so use of single inhaler as both maintenance and reliever is the basis of this therapy, and it's mainly with this some sort of physical properties of Formoterol they use. And thing is the use of the risk of dangers of using SABA-only treatment with asthma. So they have noticed all these things, especially in adult patients. but this therapy, this approach, they have shown there's no additional benefit. It's over symptom control in step 2 treatment if we consider over ICs. But the thing is, in step 3 and beyond, so it can be used as a reliever as well as the controller. So this concept of anti-inflammatory reliever is important, and one of the advantages it's improve the compliance. But the thing is, there's no supportive evidence to support or the convincing evidence about safety data, efficacy, and all these things in children less than 12 years. So because of that, it is not recommended for this age. So this need more studies, especially safety and efficacy. So till that, it is still not a smart option in small children, but it might get some popularity and possibly a smart option in older children and adults. Thank you. And if you have questions, you can type it using this Q&A option. So one question is, can asthma be diagnosed in infancy? If so, how to differentiate from bronchiolitis? Yes, so this is one of the controversial point. So initially, earlier we thought, or sometimes there may be teaching as well, asthma cannot be diagnosed less than 2 years or especially less than 1 year of age. According to the current understanding of this pathophysiology of asthma, it is not impossible to diagnose asthma. The problem is it's very difficult to diagnose. So the thing is, it is very difficult to differentiate from bronchiolitis. So the answer to this question, if so, how to differentiate from bronchiolitis, no one knows the exact answer. But the thing is, it is not impossible, because if it is fitting into this definition, if it is associated with these symptoms, reversibility, variable expiratory airflow limitations, and inflammatory changes, yes, that is asthma. But the problem is, this age, we cannot obviously show this variable flow airflow limitation. Sometimes, not sometimes, most of the time, we cannot do pulmonary function test, but some tests are available, like infant PFT available. So but sometimes other thing is the wheezing. So as you all know, wheezing is not always asthma. So most of the time it's wheezing due to some sort of viral infections. The inflammatory process is different, and it might be associated with, most of the time, eosinophilic response. So it's very difficult to give a single answer, but the only thing is, we have to assess the pattern. That is one of the important things. If this child, because it's very unlikely to have the same viral infections again and again. So that's again another thing. So can bronchiolitis can be repeated? Yes, obviously it can be repeated, but not with the same organisms. So there are a lot of controversial things about these areas, and it's not very clear, and no one knows the exact answers to these questions. But according to the current understanding, so to diagnose asthma, especially less than 1 year of age, so we have to consider the pattern, the response to treatment, and the family history. So other factors also have to be considered. Having said that, it is very important, there would be significant amount of asthma mimickers in this age. So this age, that's why it's very difficult. So we have to always keep in mind, open mind, but diagnosis asthma is not impossible in this age, according to the current understanding of this disease. So next question is, any advantage of having salbutamol and beclomethasone combination? If can we use it as a first line therapy? Yes. So the thing is, the beclomethasone, yes, in comparison to the different steroids, if we use the same comparative dose, there's no any advantage of using budesonide or beclomethasone or fluticasone. So there's no superior steroids in comparison to each other. But that's why our current management, we use either steroid plus intermittent salbutamol dosing. So that is the currently available therapy, because that's the one we have safety data. So we don't have safety data or the data on efficacy of this MART treatment or use of Formoterol in small children as a reliever therapy. So currently we use short-acting bronchodilator agent as the reliever therapy. So yes, definitely salbutamol and beclomethasone we can use as the first line therapy. So how many puff we can use during acute symptoms? It is not clear what you have mentioned the which puffs. But if we use this Formoterol contained as a reliever medication, so the maximum we can go is 12 puffs according to current available preparations containing 6 micrograms of Formoterol. But if symptoms are going on, we can use short-acting bronchodilator agents. There's no upper limit. Usually 10 puffs at a time we are using, and we can repeat it. The problem is if the response is poor to inhaled bronchodilator agents, we might have to consider IV form. So that's a danger. But otherwise, there's no upper limit. The only thing is we have to assess the response. If the response is poor with repeated inhale puff or the inhale bronchodilator agents, then obviously we have to consider IV. But otherwise, there's no upper limit to how many puffs. But usually 10 puffs equal or possibly superior to 1 shot of nebulization. 10 puffs contain 100 micrograms of salbutamol. Can ICS cause Cushing syndrome when used for prolonged periods? So the data on this is very limited. I don't think it can cause Cushing syndrome. Possibly it might induce some sort of adrenal suppressions for prolonged use, but that's why it's important. That's why we should promote this inhaled corticosteroids, especially patients also have some concerns about the side effects of steroids, but that's why the beauty of we are using this inhaled steroid. The cumulative dose is very, very small. I don't know about any isolated case reports, but in generally, usually inhaled corticosteroid does not produce Cushing syndrome, but yes, possibly adrenal suppression would be possible. Other side effects also would be possible, but very, very minimum. And in comparison to the effect of this inhaled steroid, side effects are very, very minimum. So what's the recommended period for controller therapy using combined inhaler? So that is, we cannot say the period. Only thing is we have to give sufficient time to achieve the symptom control. Once they achieve the symptom control, then we can consider stepping down. To consider stepping down, at least there should be 3 months of well-controlled symptoms. But other things we have to remember is not only the symptom control, which we decide the possibility for this stepping down. Other important thing is there should not be any significant risk factor for exacerbations. We have to consider both these aspects, but clinical practice sometimes we forget about this second thing. So both symptom control as well as child should not have significant risk factors for exacerbation. For example, if the child require ICU care, it's a significant risk factor. Or if a child requires ICU care and intubation due to asthma, that is a lifetime risk factor. For say a child requires ICU care and intubation and then started on inhaled steroid, now child is very well for say 1 to 2 years. If we consider only the control, yes, definitely we can step down, but with background that history of severe exacerbation, definitely we should not step down. So the duration is depend on the degree of inflammation and other factors. So there's no duration, or we can say the cutoff limit, all depend on the symptom control. But once the child achieve the symptom control, always we can consider stepping down if this child doesn't have risk factors for exacerbations. So when they are not having symptoms, are they still supposed to use combined inhaler? Yes, that depends on the step. So that's why it's important to assess the child stage. So 2020 GINA, they have now clearly advised what is how we should start or decide about the initial step. So depending on the initial step, if you think this child is belong to step 3, that means he's having symptoms more than like twice a week, like almost daily symptoms, then we have to start symptoms daily. And then after starting treatment or after starting combined inhaler, if they say after starting after 1 month, child got symptom control, but now no symptoms. So your question is, when they are not having symptoms, are they still supposed to use inhaler? Yes. So 1 month is not sufficient. So we have to wait at least 3 months to consider stepping down. So it's not the same. So we have to consider all these factors, and these principles also important. So yes, even the child has symptom control, our plans, and we should have clear plan, and to consider stopping or stepping down. We should not stop. It should be step down and finally stop. To consider symptom control should be there at least 3 months. Then you can consider this child might not need combined inhaler at the moment. Steroid inhaler would be enough. Like that, depending on the situations, you can consider stepping down. Are there LABA steroid single inhalers now? Yes, it's available. LABA is Formoterol and steroid inhalers available, and even the salmeterol. So this combined inhalers are available. Yeah, place of ipratropium inhaler. So ipratropium, there's no added advantage according to the current available evidence. So the question is, what is the place of ipratropium, especially in young infant? Even in young infant, we can use salbutamol. If we use salbutamol properly, proper way with a good inhaler technique, I think there's no added advantage of adding ipratropium. But some situations, in uncontrolled situation, we might consider. But other thing is tiotropium. The long-acting ipratropium, there's a place, especially for uncontrolled symptoms. Now, Gina has advised to use in children over 6 years of age. In 6 years, we can use. That is after step 3, especially step 4 to 5 patients, or sometimes maybe even step 3 to relieve symptoms. Long-acting ipratropium might have a place, the tiotropium, but short-acting ipratropium, there's no added advantage over salbutamol. Yeah, so the same questions again, use of inhaler steroid for more than 2 years due to high risk factors without stepping down, can it have any systemic side effects? Yes, it's possible to have systemic side effects, especially like as I mentioned, some sort of adrenal suppression like thing. But always, as in any other thing in the medicines, we have to consider risk versus benefits. If this child really required, if we reduce this inhaler steroid, if child develop acute asthma attack, then he might need further higher doses of steroids. Then the problem would be worsening. So all depend on your risk assessment about the future asthma exacerbations as well as the current control. So if it is not required, yes, obviously you have to step down and gradually stop it. But if it is required, yes, definitely you have to continue. The time duration of irrespective, but that group is very, very small. It's uncontrolled asthma patients, step 4 and 5. And even step 5, we might have to use oral steroid as well. But according to the current available data, the large group is fit into this step 2. That's why this Gina step, this graph, they have given a larger surface area for the step 2. So we can manage most of the time in step 2 and 3, most of the patients, but some might need prolonged thing. But if it is required, yes, we have to give. So that before considering the side effects, we have to think about the effect. But we should be justifiable. It should give benefit, not harm to the patient. Can we use salbutamol in a less than 6-month-old infant? Yes, this is again a controversial issue. The thing is, we don't know when this beta receptors develop. It's a process. We cannot say less than 6 year no receptors, more than 6 year receptors are there. So it's all depend on the child's development, other factors. So it's a gradual process. Yes, definitely we can use salbutamol inhaler. Only thing is we have to assess the response. So this preschool visas, the main approach is that we can use all these things as a trial. If there's no improvement, we have to discard it. But if there's improvement, yes, we can use. So the same thing apply for use of salbutamol less than 6 months as well. I think that would be enough for today's discussion.
Thank you, sir, for that interesting and insightful presentation. I'm sure it's a value addition for everyone. Dear participants, thank you very much for your participation. We will be signing off from today's webinar. Thank you very much. Thank you all.